I would like to thank the organizers for your kind invitation, Dr. Jindal and Claudio. Just a little bit of advice. I am a biologist. I'm not a medical doctor, so if there is any medical question I cannot address, you can write me and I will ask our medical director, Dr. Silvina Cooperman. I think she's also connected today, so maybe she can answer your questions. So I am a biologist. I have been working for the last 15 plus years in blood banking and hematopoietic progenitor cell processing for transplantation in children. I will start presenting our hospital and some data from Argentina and our blood bank timeline. I done a little bit of our work, and at the end we'll show you just 2 slides regarding regulation and some controversial issues in Mongolia. So our hospital is a public hospital in Buenos Aires, Argentina. It opened in 1987 and has become the leading public and high complexity pediatric hospital in our country. It is a highly specialized medical center with almost 4,000 employees, state-of-the-art technology, and a progressive care management of patients. The hospital has operated in an autarkic manner and is financed in an 80% by the federal government and 20% by the Buenos Aires city government. Guided by these 4 values, our vision and mission statements include to become, Our vision and mission statements includes to become a reference center and work toward the development of our society in a leader incorporating new scientific advances and new management models in order to improve the quality of life of our patients. Each year, more than 600,000 outpatient medical consultations and more than 26,000 hospital discharges are performed. The hospital has over 500 beds, of which 132 are intensive care and transplant program dedicated beds. More than 10,000 surgeries are performed. The hospital has been pioneer in the development of telemedicine communication. For 20 years, it has been training teams and attending consultations in coordination with other hospitals throughout Argentina, facilitating the local solution of problems and avoiding the unnecessary transfer of patients to the capital city. The hospital teaching and research area coordinates research and knowledge production activity for both our human resources and for other health professionals, technicians, and administrators throughout the country. So our area of images and intervention is in full modernization. It has the only public pediatric radiotherapy services in which a second linear accelerator was installed last year. It also has a central laboratory that processes over 2 million tests per year, a tissue bank, a tumor bank, and an ABB accredited blood bank, and an ABB accredited umbilical or blood bank. So a little bit of Argentina. Argentina is the southernmost country in South America. It has a population of almost 45 million people, 92% is urban population. Our gross national income per capita is 17,600. Current Argentina Human Developmental Index is 0.8, ranking 48 worldwide. But as Human Development Index does not reflect the inequalities, poverty, human security, and other social variables, when this value is discounted for inequality, our country falls to 0.7140. So a loss of 14% due to inequality in the distribution of the dimension indices. The average for very high human development countries is 10%, and for Latin American, it can be as high as 25%. Now, in our country, official number of poverty is 35% and will be higher this year according to projections made considering the global economical crisis that would follow this pandemic. So before I talk about our cord blood banking activity, I would like to show you some of the hematopoietic transplant activity in Latin America. So although the hematopoietic progenitor transplantation is performed in approximately 75 countries worldwide, the access to this therapy is unequal. Most of the transplants are performed in Europe, North America, and in some countries in Asia. So Latin America has 28 countries and a population of over 100 million, approximately is 10% of the world population. But these countries are very unequal considering social and economical development, as I showed you before. So it is considered that in Latin America, the transplant ratio is 20 to 40 times lower compared to Europe and North America. You can see that Brazil has the biggest population and also the most transplant activity, followed by Argentina. And for these authors, the reason why there are few transplants in our region are summarized in these categories: economics, political, social, personal, and infrastructure. So, but for this author also, these categories are somewhat arbitrary, and finally political decisions are the determinant for every economic policies and subsequently define the country wealth in many instances. So in order to understand our activity, you can see that in Latin America, these are the countries that do perform hematopoietic stem cells, countries that do not, and countries with missing or uncertain information. So for you to have an idea, in this paper, they show that there are 7,000 approximately autologous transplants in this period of time, and 4,400 approximately of allogeneic transplantation, being the unrelated donor transplant less activity. So for this time in Argentina, they were performing 6,100 transplants. So focusing now in cord blood, as Claudio shows before, these two tables show some milestone for this source of hematopoietic progenitor cells. In 1988, the first successful transplant was done for the treatment of Mongolia anemia. It was a related donor transplant where the cells were collected and cryopreserved in the USA and then shipped to France in order to perform the infusion. Then in 1992, the New York Blood Center opened the first cord blood bank aiming to preserve cells for unrelated patients. Finally, in 1993, the first unrelated cord blood transplant was performed at Duke University in China. So, meanwhile, in our hospital, I will show you during the next slide how we were, what's happening in our hospital and how we were working with umbilical cord blood stem cells. As I mentioned before, since the opening of the hospital back in 1987, the blood bank and transfusion service medical staff was involved with the harvest and processing of bone marrow for pediatric-related transplantation. The bone marrow transplant unit treated patients for both malignant and non-malignant conditions in the hospital. During 1995, they received umbilical cord blood collection training, and blood bank staff validated the processing, cryopreservation, and thawing of this new source of cells. In 1996, the related program was opened, and families were enrolled if they receive a medical order for the treating physician. So patients in our hospital that were under treatment for a malignancy or non-malignant condition for which the hematopoietic transplant was a future treatment were invited to enroll, signing an informed consent. Finally, after the first 3 or 4 families were enrolled, in 1997, the first related cord blood transplant in our hospital was done for a girl with an immune deficiency. So she has received previously a graft, a T-cell depleted haploidentical transplant, and she lost the graft and then was transplanted with cord blood. After more than 20 years, she has fully engrafted the cord blood cells and has recovered the immune function. So between 2000 and 2004, there were 2 important events. First, the related program became nationwide, and we were able to enroll patients that were not attending to our hospitals. So this is a map of Argentina. You can see how large it is. And this is the distribution you can see here, inhabitants per square kilometer of our population. Here is our Buenos Aires city, where the hospital is located. So the knowledge was already established in our hospital, in our facility, to start the unrelated program, but the economical crisis in 2001 in our country left this project without funding. So in 2003, the INCOCAI, which is the National Authority for Solid Organ, Tissue and Cell Procurement, established the Hematopoietic Progenitor Cell Donors National Registry. And the same year, they presented a draft for the first cord blood bank regulation that was effective in 2004. Finally, in 2005, a funding proposal from the Ministry of Health was opened and our project was approved. So our hospital received equipment and supplies for the processing and cryopreservation of the first 600 units. And we became operational by the end of 2005. Imagine that the processing facility and the cryopreservation room was established inside the blood bank under the same quality system, and the cord blood bank was licensed by the INCOCAI following that regulation. So we were collecting cord blood in 3 and then in 4 fixed maternities, and also we were offering the collection kit to families and OBGs in the city of Buenos Aires. We developed the logistic necessary to pick up the collected cord blood and establish the donor eligibility. We were outsourcing the HLA typing of the units, and even if in our hospital there were already solid organ and stem cell transplant program, we did not have an HLA lab in our hospital. So a cost analysis was performed to evaluate the convenience of opening an HLA lab in order to test the cord blood units. In late 2008, the HLA lab became operational and started testing the units and provide services to the transplant programs in the hospital. Finally, in 2009, we started asking ourselves all the question that Claudio mentioned in the previous talk. So are we ready for the ABB assessment? We do have the engagement of management and staff. The medical director, the hospital medical director provided authorization. The hospital were funding for the cost. We also get some extra funding from Fundación Garrahan, and we work with a consultant, Cindy Elliott. She came to the hospital and worked with us for 2 weeks and provided guidance for initial accreditation. We followed all the steps that Claudio mentioned. We communicated the intention to ABB, sent all the information regarding our activity, enrolled as an institutional member, complete the tools that took us over 3 months, self-evaluation, document master list, quality control overview, medical director credential, request for variancy. We needed to ask some variances to the standard. And ABB analyzed the documents and variances, and then finally they approved the variances and established the assessment date. So during the assessment, the assessor asked for documents, she reviewed complete forms and label, interviewed personnel in different roles, verify installation qualification, operation and performance qualification of equipment. She do direct observation of the processing of cord blood units, visit one of our collection centers and observe cord blood procurement. The assessor found two non-conformities and provided the recommendation to accredit after receiving the corrective action plan. So we presented the plan properly and received our certificate of accreditation. So by 2011, we were collected units from 7 affiliated remote collection centers in Argentina, more than 1,000 kilometers away the processing lab facility, and 4 affiliated collection centers in the city of Buenos Aires. We start moving our initial nucleated cell threshold for processing in 2009 to 100 million cells. So we also were working during 2011 and 12 on a new building, the design of a new building for the blood center and the umbilical cord blood bank. This new building will have a separate entrance for our blood donors, separate from the one that uses the patients in the hospital. We will have an office for the cord blood donor staff and a restricted area for the HPC processing that includes the processing lab and a clean room, the HLET lab, and a nuclear preservation room with centralized liquid nitrogen supply and a donor record room. So moving to the new facility, the same year the ABP reaccreditation was scheduled, was a challenge, but successful. And for that, you can see that a lot of people work to make this happen. After that, 3 more assessments were done every 2 years, including the whole blood center. So more people was involved in this stressful but very educational experience for those who wants to improve patient care using quality as a powerful tool. So finally, last year, we were working on a new data management system for both program related and unrelated cord bank. We were paper-based since the beginning, and after using for 15 years a lab-developed access database and reports and many Excel spreadsheets, our hospital IT department approved the budget for developing a web-based system. So this project took over a year to fully develop. The test environment were used in different stages, and finally, last July, we moved to production, migrating all the information from the other sources to this comprehensive system. And this year surprised us with the pandemic being declared on March by WHO and a huge restrictions in our country. But I will address this later. I will share you something of how are we coping with COVID-19. I would like to show you now some results of our work. So this slide shows the first 20 years of the related program. Those are cord blood collection directed to a patient. This program enrolled more than 900 families as today. Here you can see an analysis done, including the first 774 families. We were able to collect units for patients coming from every province in Argentina, and also patients and cases from neighbor countries, Bolivia and Paraguay. And you can see that when I say we, I'm talking about a group of hardworking girls, which are in this paper. And most of the cases for which the referring physician asked the collection and cryopreservation of the sibling cord blood were malignant condition, of the pediatric population. Most of them are acute leukemias, but also there were more than 50% of non-malignant hematological conditions such as thalassemia and immune deficiency. When we analyzed the sibling donor compatibility, we found that 32% were HLA-6 out of 6 matches, considering low resolution, locus A, B, and DR. An extra 11% also was partially compatible, considering 4 or 5 out of 6 matches. As you may already know, not all cord blood collection would have an adequate cell dose for a transplant, and that would depend on the weight of the recipient. So of those compatible units, only 1/3 have an optimum dose of total nucleated cells and CD34 positive cells. Finally, 24 patients received transplants. In 5 cases, an extra dose of cells was obtained from both marrow from the same donor on the same day that the cord blood was formed. And the survival at day 100 post-transplant was 83%, similar to what is published for this source of hematopoietic progenitor cell. So this slide shows some initial results that we analyzed along with the National Registry of HPC donors back in 2012. Because one of the purposes of public or unrelated cord blood banking is to provide HLA diversity in a national registry by collected units from ethnic minority. In this work, we compare the estimated haplotype frequencies from adult donors and cord blood donors. So the donors were classified according to the region of the country they were enrolled. So 5 regions were defined according to this. And umbilical cord blood donors were classified according to the ethnic background. So it is mandatory, according to local regulation, to capture this information in order to inform the registry the genetic background of the donor. So we define and analyze 2 major groups of cord blood donors. According to the ancestry, Latin American born with European ancestries and Caucasian were grouped in one group, and we compare with the native South American background. So the remaining are considered mixed or other ethnicities, and were not included in this analysis. So what we found is that there are 2 haplotypes that were more frequently found among South Central Northeast and Cuyo unrelated donor, adult donors, and also in this group of Caucasian ancestry. However, there were 2 populations that show a different frequency distribution: native South American and the Northwest adult donor. So what we found is that these 2 groups of donors, native South American and this area of the country, were provided an additional source of ethnically diverse donor. And the INCOCAI make all these donors available worldwide through the bone marrow donor database. So another thing that we also analyzed was the effectivity in different maternities. So as I mentioned before, our cord blood bank collects units from affiliated maternities, but in order to consolidate the concept of altruistic donation in the general population, it was also offered to donate cord blood to mothers who give birth at non-affiliated maternities in the city of Buenos Aires. For
Hello.
the affiliated,
Hello.
Yeah. For the affiliated maternities, there is a service agreement, so healthcare professionals are also trained in the eligibility process and collection of the units. But in non-affiliated maternities, agreement was made between the bank and the healthcare professional directly. So the OBG receives written instruction to enroll the donor and perform the umbilical cord blood collection. So with the purpose of optimizing the operation of the bank, we analyze the products that are procured at affiliated versus non-affiliated maternities, and we compare pre-processing discard rates and reason for discarding units. So even though the collection method, eligibility criteria, and threshold for initial volume and TNC were the same, we found that effectivity, that is calculated as the percent of unit processed over unit collected, was different, and it was almost twice higher for affiliated maternity. So considering that continuous on-site training of healthcare professionals might be the best tool to optimize the initial volume of the unit collected, I'm finding that the affiliated maternity has 32% of the unit that was excluded by low volume, and non-affiliated maternities were excluded more than half of the units. So we decided that we will not enroll any more donors from non-affiliated maternities, and will focus all the human resources that we have been using these maternities for the training of healthcare professionals at affiliated maternities, with the intention to even increase more these effectivity rates of units that are collected and processed. So other thing that we were also analyzing is that as volume reduction is widely used in umbilical cord blood banking, and the purpose for this is to obtain a progenitor cell concentrate by reducing plasma and red blood cell, optimizing the storage space. When you use a volume reduction methods, it's very important to optimize the progenitor cell recovery, that is estimated generally using the total nucleated cells recovery. So it has been published that TNC recovery using a top and bottom procedure among different age subgroups reveal an impressive rate with the aging of the unit. And by ages, I mean hours from collection to processing. So the aim of this study was to analyze TNC and mononuclear cell recovery in umbilical cord blood units processed with an automated method at different age subgroups. We also analyzed the CD45 positive cells viability in these groups. So we retrospectively analyze all this unit processed by the CEPAX machine, the same protocol. And then the enriched fraction, the cell enriched fraction, was sampled for cell counts and viability testing by flow cytometry. So what we found is that when the unit has more time from collection to processing, the TNC recovery was higher, and this was significant. But the mononuclear cell recovery didn't change over time. And of course, as you may already guess, the viability was lower in this age group. So TNC dose is one of the most important parameters associated with umbilical cord blood transplantation outcome, and is a well-standardized variable to estimate the cell content. And currently, all cord blood banks try to optimize the time and the procedures to recover as many TNC as possible from cord blood units. So a previous work showed that TNC recovery increased with the age of collection, but the CD45 viability decreased. We also show here. Our finding confirmed these results using another processing method, and show that mononuclear cell recovery, which is a better estimate of progenitor cell recovery, was not different with the aging of units. So this information should be considered at the time of establishing the acceptance criteria during performance qualification of any automated processing system for volume reduction. Just now there is a conflict using TNC for medical decision for selected a unit for transplants. If the unit was processed during the same method but at different time, a unit with lower TNC could have the same quality and potency for the transplant. So it will be worthwhile to investigate a biological phenomenon that can explain these results and how this will affect the policies regarding what time after collection would be best for start process. So another thing that is important in a cord blood bank is to develop a program to evaluate the donor baby sometime after delivery as an attempt to find any transmissible infection, genetic or inherited diseases not detected at the time of collection. So we established a routine program for evaluated donor infants 12 months after umbilical cord blood donation. Of the 3,600 mothers we enrolled in the study, 81% were contacted by phone to report on the health condition of their baby. There was almost 20% of them that could not be traced. And several diseases were detected by this method between 12 months after umbilical cord blood donation in the donor infant. In those cases where the detected condition made the donor ineligible, the unit was removed from the inventory, from the public inventory. We found that 1% of the units were removed from the inventory for this interview. One collection was also reserved for later use in the donor himself because he developed neuroblastoma. You can see the kind of information we get from this interview. So our data support the feasibility of a routine 12-month program for the evaluation of baby giving cord blood in our public cord blood bank. We believe this program are really important because may increase the quality of our inventory for transplantation. So during the last 3 years, Valeria was incorporated to our hospital. She is a full-time researcher at the CONICET, the National Scientific and Technical Research Council. She has been previously involved in stem cell research. She developed induced pluripotent stem cells for disease modeling. Now she's running 3 projects in our cord blood bank. One is ex vivo expansion of HPC from cord blood, a phase 1 clinical trial for autologous use of fresh cord blood for hypoxia ischemic encephalopathy of the newborn, and also developing a tool to understand biogeographical ancestry in cord blood donors and their relation with polymorphism of the HLA system. She's focused on the research and development of new cell therapies from cord blood following current GMP, in order to be able to translate it quickly to the patient. So some of the work, it was the validation of the product that is used for the clinical trial. Cells were delivered fresh in small doses to be infused during the 2 or 3 days after the baby was born. So phenotypic and functional assays were performed to demonstrate the potency and the safety of the new product. There have been infused 12 patients already, and the analysis of the data is being prepared for the 6th time.
Sorry.
Yes?
We had 2 more minutes, please, for your presentation. Thank you.
So, just a little bit about the regulatory environment. In our country, there are high hierarchy regulation, like laws and decrees, and also the INCUCAI, and I show you just the 2 norms that are mandatory for cord blood bank in Argentina. So one is from 2004, the licensing of cord blood bank, and since 2012, there are the norm for the GMP for any lab that is going to use cells for medical treatment. So just showing you the index, this is mandatory for us, and we are considered HPC Minimal Manipulation. So these kind of norms are harmonized with other international norms. But in the controversies, I'm thinking about what Claudio presented. One of the questions that we do in this area is, this is a frequent question, how big should the cord blood inventory be? So you may have already noticed that it is a costly process and the use is minimum. At the beginning, less than 1% of the inventory was shipped for transplant. During the following years, and depending on the size of the cord blood bank and the ethnicity they represent, there might be a higher use of bank units. According to the World Marrow Donor Association, approximately 5% of the inventory in their global registry has been used for transplant, mainly from the biggest cord blood bank. So when you see HPC transplant trends, according to Cellular, so peripheral blood keeps going up as the main source for transplant, followed by bone marrow, and finally cord blood. So the other variable to consider is how often we add a new unique HLA donor or cord blood unit that was not previously represented in the registry, as the registry goes bigger and bigger. So now there are 37 million donors and more than 800,000 cord blood units available for unrelated transplantation. So this question rises, who are we banking cells for in Argentina? So according to Aikaj data presented in 2016, if you consider globally, the umbilical cord blood bank is used only in 1% of the transplants. If you consider only patients under 15 years old, 8% of the transplant use umbilical cord blood. In Argentina, the allogeneic unrelated transplantation accounts only for 10% of the activity. If you see in the time, the use of cord blood in our country has been falling from 1820 to less than 5 each. So, and here are the number of licensed HPC transplant facilities in our country in 2017. Now there are 2 other provinces that are also performing bone marrow transplants, but for pediatric patients there are less transplant team license. So this is not only a trend in Argentina, it's also viewing globally. Compare data with the CIBMTR, you can see that in the adult population, cord blood use was approximately 8% in 2016. And in the case, if you only consider patient under 18 years old, the main source for stem cell for transplantation is bone marrow, followed by cord blood and then peripheral blood. In 2009, there was 80% of transplant performed with umbilical cord blood, but this trend is going down. And in 2016, cord blood was used in 80% of the patient. Most of the patients that receive cord blood are from ethnic minorities, so they do not have a perfect match in the registry, and uses cord blood as the source for the transplant. So as I mentioned before, I will say just 2 slides about what happened in 2020. We were working with 13 affiliated maternities. Most of them were remote collection centers, so we received the cells from an airplane, and the other one that were close to our processing facility were by land. So when during February and mid-March, there were no new regulation requirement because of COVID-19 pandemic. We all thought that mother-to-child transmission is unlikely, but we do ask some screening question, follow the recommendation, the international recommendation and local recommendation. But in March, when the WHO declared the pandemic, there was a major disruption on domestic transportation here in Argentina, and it is still all the activities stopped. So we were thinking about how to mitigate the risk for donor and also mitigate the risk for our staff. So because collection staff is moving between one donor to another for consent and collection, that might increase the risk of spreading the virus. So we cease all public collections, but continue to collect and private self-directed public units. And for that, there was a lot of efforts for getting timely the units from all over the country. And we receive a lot of Aikaj support because they keep operational for solid organ and cell transplantation. And we face some viability challenges, receiving units that were almost 48 hour age. So, this is a picture of our recipient of this directly cord-blood units. So what happened with the staff? Umbilical cord-blood staff start doing other tasks in the blood bank.
I would request you to wrap it up, please.
Yes. There's the last one, the last slides, just 2 slides. So they start working from home. The processing lab staff also process bone marrow and peripheral blood. So there were a lot of requirements to cryopreserve, not only for patients in our hospital. We were asked to provide this service to other transplant units. Of course, the shared spaces were rearranged. And for working from home, we were updating SOPs, analyzing data validation, our annual continual education. But there were other effects also. We were not able to continue research projects, considering non-essential workers, they cannot leave home, except it is a COVID-19 related research project. So, and we don't yet know what will happen with the hospital budget next year. So, we are thinking how to resume activities in cord blood. We have a plan, but reality is that we still don't know when domestic flights will be operational here in Argentina. And we were planning to select only some collection center, but using which criteria? The logistic, the ethnic diversity, or collection efficiency. This is all I have to share with you. Thank you.